Welcome to my podcast, The Lower Down Experience. Many of you will know me from my Instagram page at Fabulous Pharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke with Dr. James Mulvany. He is a consultant paediatrician with a specialist interest in ADHD and neurodevelopmental behavioural disorders. We answered so many of your questions about ADHD, and I know that so many of you are going to get an awful lot from this podcast. To support the Lower Down Experience, please check out my sponsors in the podcast notes below. Enjoy the show. James, thanks for joining me today.
Great to be here.
To talk about ADHD specifically, and then developmental and behavioural issues in children. So there was a huge interest in this podcast. When I put up a question box, I got hundreds and hundreds of questions. There's obviously lots of parents out there, and then there's adults out there that think that they have it too, and they're wondering how to go about it. So first and foremost, you're a paediatrician, general paediatrician.
That's right, yeah. I'm a general paediatrician working predominantly in the community in Melbourne, Australia. And I work in a multidisciplinary clinic incorporating general paediatrics, as well as a team of allied health professionals that help support our work. And, we do see kids across the spectrum of paediatric issues, from, early infant feeding to asthma to, diabetes. But a particular area that we deliver a lot of care in is in neurodevelopment and neurobehavioural disorders in children and adolescents. And how did you get into that field of paediatric practice yourself? What drew you to it? Well, it's a really rewarding area to work in. I mean, the impact on families and children and adolescents that are successfully treated for conditions such as you mentioned in the introduction, attention deficit hyperactivity disorder, is a big part of what draws clinicians to the field. Contrasting to the experience in Ireland, a lot of that care is delivered, in fact, by paediatricians as opposed to child and adolescent psychiatrists. So it's a more common pathway to segue into as a clinician in Australia, and that's obviously where I did the core of my postgraduate paediatric training. Okay. And would you, almost dedicate your career to the fact that you had an amazing older sister who really kind of, showed you? I didn't think you were going to let the rabbit out of the hat that quickly. I was anticipating, a better punchline. No, I'm
James
joking,
James is my little brother, by the way, just to get that out of the way. He's three years younger than me, so he had me to look up to throughout his whole childhood, and I traumatized him as well, because he was regularly mooned and flashed at. As a result, he was never afraid of the female body, though. So we'll put that out there.
It maybe inspired me to pivot into behavioural disorders in children and teens.
Quite possibly, given all the trauma that I caused you as we grew up. But anyway, getting straight to it, what is ADHD?
Yeah, it's probably wise to crack on. Look, I mean, ADHD is topic du jour at the moment, certainly in Australia, and I think that is kind of filtering through both in social media and the mainstream media in general in the developed world, essentially. But ADHD, the textbook definition of it would be a chronic neurobehavioural disorder or neurodevelopmental disorder. The core components or symptoms of which are inattention, and or hyperactivity and or impulsivity that cause substantial functional impairment in multiple contexts. And those contexts for children and adolescents are generally in the home setting, the school setting, and then for older adolescents and adults in an occupational setting, as well as socially. And
so you just said it's the topic du jour. So we're seeing a lot of it at the minute. We're seeing a lot of people on social media coming out as such, saying, "Oh, I'm an adult with ADHD. I've just been diagnosed. It explains a lot. It explains a lot about my childhood. It explains a lot about the trouble that I was in school, etc., etc." But is it so? Why? How come it's more prevalent nowadays? Is it are people born with it? Is it to do with the environment that we're living in? It's all fast. We're on our mobile phones all the time. We're getting instant gratification. Our attention is being it is being deflected from 1 minute to the next. How does it come about?
Well, look, I mean, I don't think that the prevalence necessarily has increased. I mean, depending on what study you look at, between 3 and 7% of the general population would be affected by ADHD. I think it's just that it's more recognised now. People have more access to evidence-based assessments and treatment for ADHD. So, I mean, it's been well recognised in the medical literature since the 1800s, in fact. The first sort of case reports of children with what would have been historically referred as hyperkinetic disorder, or there's been lots of different nomenclature used to describe the entity that is now known as ADHD. So this is not a new thing. It's been around. And, currently people probably still are, not receiving timely and adequate assessments, nor are they obtaining, adequate treatment.
Yeah. And is there a genetic component to it?
Look, it's a heterogeneous disorder.
What does that mean to the lay people, James?
Multifaceted. There's many components to its sort of, biological origins and presentation. There's a very strong genetic and hereditary component, although like single gene causes haven't been identified.
I was speaking to one psychiatrist who deals with it, and he said that it never skips a generation. So if you look, if someone in your family has been diagnosed with ADHD, be it your child or yourself, and if you look back on generations of your family, so say like your uncles, your aunties, or like your grandfathers, you can if you can go back that far, you can pinpoint people that have traits of it, definitely.
Yeah, that's correct. Look, I mean, that it doesn't skip a generation might be a stretch, but there's certainly a very strong family component, hereditary component, and that's supported by family and twin studies.
Okay.
So it would not be uncommon in somebody that is recently diagnosed with ADHD, or through their own research thinks they may have ADHD, would recognize similar features and traits in other family members. Yeah.
And then, in terms of, say, it's always been there, but now we're more open to this kind of a disorder. Is it considered a mental disorder or a mental illness? What is the...
Well, it's a chronic neurodevelopmental disorder. I mean, it can be classified as a mental disorder depending on who you're speaking to.
Okay.
It has neurobiological origins. There are functional MRI studies that look at the specific parts of the brain that are involved in ADHD, demonstrating reduced efficacy of neurotransmitters like dopamine and noradrenaline. But we can kind of have a broader discussion about that maybe a bit later.
Okay. And I think we can all think back to, say, I remember in school anyway, there was always a couple of kids, say, that acted out, or they were always in trouble, or they, their behaviour was wrong, was bad. They were constantly doing things that the teacher told them not to do on a regular basis. So when I think back to those kids, I can probably see, when you look at the list of traits for ADHD, and there is a DIVA assessment form that you can look up and look for traits off it. Like a lot of people would, not a lot of people, but people would have ticked those boxes. So it does, I do kind of look back on those people that I was in school with and think, God, they were people that never got looked after properly or never got assessed properly. But I suppose that's just, that's just the way of the world, isn't it? Like, it's great we're making strives to look after these people now, but there are generations of people that weren't looked after, I suppose.
Yeah, absolutely. But that's, I mean, there's been a big movement away from stigmatizing those with, more general mental health issues, like even anxiety, depression, bipolar disorder. And it's great to see that. But yes, there are generations of people that would have missed out on effective treatment, or would have been misdiagnosed with other entities like, I've mentioned. because the fortunate thing is the treatment is really, really effective. And again, we might park that and get to it, but there is no other mental health, if you call it a mental health disorder or a neurobehavioral disorder, that responds as effectively to treatment as ADHD, and that's backed up by decades of literature in medical journals and such.
So can we talk a little bit about the treatment? Because I think it just, how is it, what's the best way to treat someone with ADHD, or how should someone go about getting them, if they think that their child is displaying symptoms of it? So talk me through what some of the symptoms might be, because I have had questions in saying, does my 2-year-old have it? My 2-year-olds, or how can I tell if my child has it?
To that point of a preschooler, can preschoolers be diagnosed with ADHD? Yes, but in extreme, cases, if you do an ADHD screening tool on a preschooler or a toddler, they will invariably score very highly, because most, toddlers have limitations to their capacity to control their impulses, regulate their emotions, concentrate and focus for sustained periods of time.
Okay.
Look, maybe it's best to kind of describe it by way of example in terms of how it works in my own practice.
Yeah.
So, a common referral might be from a GP in the community that, there's a 6-year-old boy, let's call him Sam, and he's been struggling at school for the past 12 months, isn't matching his peers in terms of academic achievement. He's easily distracted, finds it difficult to sustain his attention for, prolonged periods of time, can be restless and fidgety, talks out of turn, interrupts the teacher, interrupts his classmates, has short-term memory issues, and that can evolve into a child being more disruptive or disturbing within constrained settings like a classroom or socially, say for example.
And a lot of them are labelled bold children as well, aren't they? Within, like, by the teachers or by their parents, and often it could be this issue that they have.
Yeah, it's correct. Just to be clear, ADHD is not a parenting problem, or in the majority of cases, it's not a problem with the teacher. It's very difficult to parent or teach a child with ADHD, and people need to be cognizant of the fact that the child does not have control over the difficulty that they are experiencing. Most of the children that I see do not want to feel the way they do, or do not want to experience classroom activities or social activities or family activities the way they do. So kids and young adults and adults with ADHD have suboptimal life experiences, and it can be detrimental to their overall level of functioning and mental health.
That's really sad, isn't it? And they recognize this as well, because I know a few people from my own practice say that, when I would have been coming in and they would have been getting their prescriptions, and we alluded to it before, the prescriptions the prescription medication or the treatment can really work well, but yeah, they said like the family life was so difficult for them. The child would never behave or need to be told constantly not to do something, but they still kept doing it. And there are children that are very high functioning, so they may not have the attention deficit part of it, so they can be do really well in school, really hyper focused in school, or perform well in class.
Yeah.
But the behaviour is the problem. And then I think sometimes we associate good academia as in someone who can achieve or meet the milestones in with their education, and then just the behaviour element of it is almost brushed aside as just bad behaviour, when in actual fact that can be the ADHD, that impulsivity that you're talking about. Or I know that you and I talked about it before. You say making dumb decisions all the time.
Yeah, exactly. Yeah, absolutely. And I mean, your listeners may read about ADHD and that it affects males more than females, which it does. I mean, statistically, boys are more at risk of it, but they also tend to present in a slightly different way, in that girls will be, less likely to present with impairing hyperactivity symptoms. So inattention is a predominant feature of young girls presenting with ADHD, and the hyperactivity manifests in different ways, in that they might be hyper talkative as opposed to hyperactive, or have more difficulty self-regulating their emotions,
Or butting into sentences all the time, like
yeah,
wanting
like,
to get their
yeah,
point of view across.
If you're a super energized young boy who is disruptive, you're far more likely to come to the attention of teachers and parents, and you're actually, you know, more likely to engage with assessment and treatment at an earlier age. So there's lots of females in the general population out there in the community that would have struggled through school with inattentive ADHD, and because you know, by nature of them being more socially equipped and not disruptive, would disadvantage themselves unbeknownst to them and their families, because it wouldn't have prompted an assessment or treatment. And I think they're the kind of stories that are filtering through in the media, particularly in young women that have had that schooling and home experience, getting diagnosed later in life.
Yeah.
But just to kind of maybe summarize more succinctly for those that are listening, ADHD, ADD, it's the same thing. So the umbrella entity is ADHD, attention deficit hyperactivity disorder. And there's two classification systems for that. One is based on the DSM-5, and we'll put all this in the show notes. DSM-5 is Diagnostic Statistic Manual of Mental Disorders. It comes from the United States, and then the ICD-10 is a UK-based model. So the DSM-5 classifies it as attention deficit hyperactivity disorder, and that can be either a combined type where you have both inattentive symptoms and hyperactive symptoms, or it can be inattentive predominant, or it can be hyperactive impulsive predominant. So generally you would classify it as such, and the clincher is that there has to be substantial functional impairment to warrant a clinical diagnosis of ADHD.
So what does functional impairment mean?
Well, look, it's a very loose term, and I mean, you're relying on narrative from parents and school teachers, and to kind of pivot back to how, you know, parents or people will go about assessment. The, you know, frustrating thing with all of this is, you know, if you contrast it to something like diabetes or appendicitis, where you can kind of have a radiological scan, like an ultrasound or a CT or a blood test that says, yeah, this is what it is. You know, with ADHD, you're requiring the story to fit within diagnostic criteria, but those diagnostic criteria, you know, aren't sacrosanct, in that you have to rely on clinical expertise to make a judgment whether, if you're not, you know, displaying a full house of symptoms, whether you would warrant treatment or not. Okay.
But the majority of people that are referred onto you, are they referred and you would generally assess them, and they would have ADHD, or would not all children or teens that are referred to me with queries around ADHD would receive a diagnosis, but you know. No. Okay. So what do you do when you do diagnose someone with ADHD? Like, what's the first thing that you do with them?
Well, if you make the diagnosis, I mean, the important thing from my perspective is you're not aiming to treat like individual symptoms. You're aiming to treat and support the functional impairment. So it should be goal based, in that, you know, if Sam, as in our, you know, example, is struggling at school, the goal would be to initiate treatment so that he can better engage with classroom activities and, you know, develop his peer relationships better.
Because there is a social element to it as well, that they can't, some people, and that's what I'm saying, some people, because it is a spectrum of an issue as well. So some people, as you said, they may be more of the attention deficit, some people may be more of the impulsivity, and then some of them, they can find it hard to relate to peers, especially with the impulsivity, hyperactivity part of it, because, you know, it's all well and good when we're all 4 and 5 and we're all running around like mad jokes, but then as we get older and someone continues on that impulsive behaviour, which can be physically, you know, they can become physical with people, they can not know when to get out of someone's space, you know.
Absolutely. I mean, it's it's a lack of inhibitory control, and to your point, you know, kids with ADHD can be the life and soul of the classroom or the family, and can bring lots of joy and fun and humor to situations, but, you know, that only lasts for so long, and then you start disrupting or encroaching on, other students' desire to learn and make progress, and, can make initiating and sustaining, maintaining relationships, not just with classmates, but with family members as well. It can be really, really hard.
Yeah.
And that's why, I mean, if a question is raised about ADHD, not saying that the final common pathway of that will be that medication will be started, but it's something that, should be looked at in a timely manner. Okay. I see lots of late teens that have come back to have reassessments, having had diagnoses previously that weren't, for whatever reason, be it poor communication of the diagnosis or treatment plan, wasn't acted upon. And that can be, it's not that it's not a salvageable situation, but, there can be lots of years wasted or lost as a result.
Yeah, because I was, I've spoken to loads of people about this, and there is so first of all, you're speaking from an Australian perspective, and we need to make that really clear, because over here in Ireland, it's generally a psychiatrist that will diagnose ADHD in a child psychiatrist really, whereas you're a paediatrician who has a special interest in this, and you can diagnose over there, and you can prescribe Concerta. But over here, Concerta, which is or Ritalin, methylphenidate being the drug, Concerta and Ritalin are both brand names, and there's other brands as well. They can be prescribed, and they can they can be miraculous in the way that they help someone. So can you explain what the drug does and how it helps? Because the drug is a stimulant, which makes people think, how can a stimulant actually, treat something like ADHD? So can you please talk us through how the drugs work?
Yeah, sure. So speaking in broad terms, the first line medical treatment for ADHD is stimulant medication. And yes, it's paradoxical in that you are looking at a child that's hyperactive and impulsive and disruptive, and you're giving them a stimulant medication.
It sounds mad,
but
it's
just like, not to get into the weeds with it, it's the way the neurochemistry works in your prefrontal cortex, which is where the problem lies. So a good way of framing it is that ADHD is a dopamine deficient state. Your frontal lobe is in a dopamine and noradrenaline deficient state, and the medication works in a way that increases levels of those neurotransmitters or messenger chemicals, which allow for more effective kind of communication between nerve networks in that part of the brain. Okay. So that part of the brain, that prefrontal cortex, is responsible for what are known as executive functions, and ADHD can be, regarded as an executive dysfunction disorder as well. So that includes things like attention, activity, impulse control, emotional regulation, time management, organization, working memory, cognitive flexibility, which are all areas that have a tendency to be impaired in ADHD.
Okay.
So some more than others, depending on the individual.
But generally, when you prescribe medication for someone, and there is a titration of it, they start in a lower dose and they can work their way up to their optimal dose. You can have the long-acting stimulants, and you can add in the shorter-acting ones. There's various ways of doing it, but in general, in your practice, and what you see is people get on well with these medications, and it can change their lives for the better.
Yeah, absolutely. Well, I mean, look, the process at the clinic I work in is that if a diagnosis is made, and we have a fairly standardized protocol within the practice amongst the paediatricians that treat these kids in terms of how we operate. So, if a diagnosis is made, medication is obviously brought up in the discussion, and we provide a pretty comprehensive educational resources to the family on that, and send them off to review, and have a think about what they want to do, weigh up the pros and cons, and then they'll come back in for a further session to discuss what a treatment plan would look like. But look, overwhelmingly these treatments for ADHD are safe, effective. They've been used for decades. Although there's side effects like there are with all medications, which we can, discuss.
What are the side effects that would stand out to you? Like,
look, the main side effects that parents would generally have concern about would be appetite suppression and associated weight loss, and concerns about growth, which haven't really been supported in the literature. I mean, you're talking about final height potential.
Okay.
You are far more disadvantaged not having your ADHD treated than you are, as long as you can tolerate the side effects. But appetite suppression, weight loss, and sleep initiation difficulty will be commonly reported side effects.
So what's sleep initiation difficulty?
So difficulty falling asleep.
Okay.
But the inverse is also true. People with ADHD often have horrendous sleep-wake cycles and sleep patterns, and
can't get to sleep till very, very late at night, early in the morning time.
Well, yeah, they've just got super active brains. It's like driving a race car with no brakes. So the stimulant medication puts the brakes on, and then they can often fall asleep more easily. So parents will often report sleep improving on treatment. However, it's a stimulant and it can keep kids and adults awake. And then more minor side effects like tummy upset, dry mouth, headache. They tend to, plateau and go away after a few weeks. And then other things include development of minor tics, which are involuntary motor movements, be it blinking, frowning, shrugging. Name a body movement that can be a tic,
like a grunt or a snort or a
but again, interestingly, like tic disorders and ADHD are common bedfellows. People with tic disorders, in and around 30 to 40% of them will have coexisting ADHD. So having tics isn't an absolute contraindication to starting treatment, because the treatment will often result in an improvement in the tics. Not always the case, but it can do.
So these issues can present together, so that you can have tics. You can have tics present with ADHD, or you can have tics be brought on by the drugs, by the ADHD medication. Is that right?
Absolutely. But in a child that doesn't have tics, I would never recommend not initiating treatment with stimulant medication, because there's a risk of developing tics.
Okay.
And often if you develop tics on treatment, they will go away with time.
Okay. And if someone is diagnosed with ADHD and they are put on medication, is that medication lifelong?
Not necessarily. Look, I mean, children and adolescents that are untreated for ADHD, 30 to 40% of them will carry impairing ADHD-related symptoms and comorbidities into adult life, and it's not possible to crystal ball how, the degree to which that will affect the individual.
Okay.
But, I mean, there are good studies to that highlight people with untreated ADHD are more likely to experience, reduced employment and academic opportunities, substance misuse issues. I mean, juvenile justice system and prisons is full of individuals that would have potentially had untreated neurobehavioral disorders such as ADHD. And that's supported not just in the literature, that's supported anecdotally in conversation with child and adolescent forensic psychiatrists that work specifically in that space.
Yeah, I've heard that too, and you were suggesting there about drug misuse, and there is that line between people that they have that racing mind, say, that they have with ADHD, and they're almost self-medicating with alcohol, cannabis, illicit drugs.
Yeah.
Because and that's the fear if children don't get assessed early enough.
Yeah.
So whatever about your young child under the age of 12 having it, once they get to the teenage years and they, all the hormones are going around their head as well. So not only do they have the ADHD to live with, they have all these hormones, and then they're going out drinking and they realise, oh, this alcohol is actually kind of calms my mind down a little bit. This cannabis, this joint that I've smoked actually makes me feel more relaxed than, say, another individual might experience, because their mind is racing all the time with ADHD, and that's where the That's where the line can be crossed, and where they can, just go down that rabbit hole of substance misuse, which is really sad.
Yeah, and look, I mean, it's not to set off alarm bells in your listeners that if there's concern about potential ADHD, that you're there's no other pathway other than substance misuse. And
no, I'm not trying to say that at all.
Justice and jail. I mean, that's absolutely not the case, but it's just an additional risk factor.
Yeah.
If you have ADHD, but yeah, those that like it kind of goes back to that low dopamine state, in that your frontal lobe, your prefrontal cortex, will seek out that dopamine in other ways. So that could be through substance misuse or
food,
or
even
food, or whatever.
Okay. And then, is there a worry or a concern that children are being over medicated? Like, anecdotally, one would hear in America, people can't get into school unless they're on Ritalin, especially like little boys normally run around like crazy Egypts, hitting each other, hitting themselves, banging into walls, and can be disruptive in class by virtue of the fact that they're just males. Yeah. So where do we draw the line at, oh, this is actually just him being a normal little boy, or this is ADHD?
It's really difficult. I mean, and because there's no blood test or biomarker that says this is ADHD, again, you're relying on the story. So in a case like that, where you've got a child who's, say, academically achieving, but from a behavioural point of view, there are issues, a perfectly reasonable option maybe just to observe over a set period of time, with modifications and accommodations made within the classroom to see if that helps, And if that's not helping, you bite the bullet and you initiate treatment,
Okay.
In terms of overdiagnosis, there isn't really, in the literature, systematic overdiagnosis and overuse of stimulants certainly isn't occurring in Australia, and it's probably not the case here.
It's definitely not occurring here. People aren't being assessed.
In the United States, it's a little different in that, primary care physicians, so GPs can prescribe psychostimulants to children and adolescents, whereas there are more restrictions on practitioners in Ireland and Australia, and that generally only paediatricians, psychiatrists, and some neurologists and GPs, in fact, that have a specialist interest and specialist training in it, can prescribe.
Yeah, but GPs will generally refer someone in Ireland to a child psychiatrist or a psychiatrist that deals with this issue, and it's by the psychiatrist that the prescription is issued and initiated and looked after.
I think so. No, look, there are paediatricians that prescribe stimulants in Ireland, and it's probably a little more common in more regional and rural areas for that to happen.
Okay.
Yeah, it's just different. It's a different model of care in Australia.
Okay.
Yeah.
So we discussed there the differences between females and males. So would you, in your practice, see more males than females?
In short, yeah.
Okay. And, you were suggesting, you said that, women can miss out because women aren't necessarily, it isn't picked up as quickly in girls. So then as they get older, they might reflect back on their lives, the way we were just talking about, and say, Jesus, I was displaying those symptoms that we're talking about, and go and get assessed, as an adult. And I know that you're not an adult doctor, and I'm not trying to put words in your mouth, and I think that's where this whole rush of people and the whole social media thing, it has gained traction.
Yeah.
So, I suppose first port of call for a parent that's worried about their child, what would you suggest that they do?
Well, it would be similar to the Australian experience in that you'd need to go to your family physician or GP and have a chat about referral pathways. In Australia, the options will be through the public or private system. But similar to Ireland, like the public system in Australia is overwhelmed. It's difficult, to get assessments and treatment. Wait lists are very long. So most people seek services privately, either from people like myself or psychiatrists. But even with that, like our clinic wait lists, and we do, share care. We do a care model where we offer public and private services. It's just the way the medical system is funded in Australia.
Okay.
So people for private consultations to see specialists get subsidies,
Okay.
no matter their socioeconomic background. So it's a little, it possibly not quite as expensive as it would be to seek purely private services in Ireland.
Okay.
But yeah, look, I mean, I would go and have a conversation with your GP and, you know, talk about referral pathways, but before doing that, I would have a look at some of the resources that will, you know, be predominantly Australian centric that I can provide to you.
We'll put them into the podcast notes, because I was looking at some of them and they are very good. Even, you know, in terms of, say, so we talked about medication. Does psychology work as well, or talk therapy? Can that help, or is the medicine really the best way to treat?
Well, I mean, in ADHD, barn door ADHD, first line treatment is medication, and that can often be all that's needed.
Okay.
But you know, gold standard, if there is such a thing, treatment involves medication and behavioural therapy, and that behavioural therapy can be delivered through you know, a psychologist or a behavioural therapist or an ADHD coach, particularly in the adult world, to help you know, circumvent against those executive function, you know, difficulties. But often it's often the case that, you know, a child and family need that defervescence of the core symptoms.
What's defervescence?
Like reduce those core symptoms before you can, you know, actively action or implement behavioural strategies. So the behavioural strategies are very important.
Yeah.
But in most cases with functionally impairing ADHD, the medication is needed, because
they basically, as you said before, cannot control their impulses. It's, you know, it's not, and no matter how many times you tell your child, don't do that. Don't do that.
They won't be able to do it.
They won't, and no matter how intelligent they are.
Absolutely. I mean, ADHD affects people across all socioeconomic groups, intelligence levels, you know,
yeah,
demographics. You know, it's really hard because there's that fundamental biological lack of inhibitory control, you know, inattentiveness, and, you know, activity levels. So
I've heard of people going to get their child assessed, and in doing so, they have to fill out assessment forms. As a DIVA assessment form.
Yeah.
And when they're filling out the form, they get a moment of realization that they tick a lot of the boxes too. Yeah. Would you see that in your practice as well?
Yeah, absolutely. Well, I'm part of a group, Australian ADHD Professionals Association, and they had their annual conference a couple of months back. And I mean, you know, I'm starting to introduce it into my own practice, of offering the screening tool to parents, because like we discussed earlier, you know, there's a really strong familial and hereditary component, and I would have parents that either already have a diagnosis of ADHD and recognize similar traits within their child and don't want them to go down that, you know, difficult pathway that they had to experience as a in late childhood and adolescence, or you get, yeah, like you say, the parent that completes the screening questionnaires and, you know, has a bit of a light bulb moment that, oh, wait a minute,
this has been me.
Maybe things
I'm reading about myself.
Could be easier for me. And look, I mean, you know, it's not to say that everyone that has ADHD by any means, you know, is not doing well in life. There's many successful, you know, people across domains of sport, entertainment, business that do really well with ADHD because they've learned to live with the symptoms, or
they've grown up with the coping mechanisms, or they've learned the coping mechanisms themselves.
Yeah, absolutely. Yeah. Absolutely.
And they don't necessarily need medication then. You know, there'll be a lot of them walking around now that,
yeah, for
well, maybe
sure,
medication might benefit them, but they've got this far.
But in terms of like performance improvement, maybe their trajectory to where they are may have been a little smoother.
Okay. And then I've had questions in saying, you know, can you calm and settle and burn that energy off without using the medication? So, and people are hesitant to take medication. And I know that GPs are, even hesitant to kind of refer people on to psychiatrists. Maybe they might prefer them to go down the psychologist route instead. With children as well, can they burn that energy off? Is there a way, could you literally stick a stick in the ground with a lead around it and make them run around? Or is it impossible?
No, I mean, look, if you have an energetic young child on your hands that, has a tendency to be a little impulsive or disruptive and, likes to move a lot, it's not, they may not necessarily have ADHD. And yes, all those kind of, supports for them, getting them engaged in regular exercise, optimizing their, sleep, making they're getting restorative sleep, eating well, all of those factors can contribute in that holistic approach to these issues. Like the medication is really important when a diagnosis is made and it's first line and it works really, really well, but it's not the only thing that you can do to help your child.
Okay.
I feel the issue for most families with children that are struggling is that they will find it very difficult to access assessments and treatment.
Yeah.
Because in Australia, Australia isn't some dystopian world where everything works well and there's no similar issues, but waiting lists are long and it takes time. And
that's the problem though, because and that's the crucial problem, because a kid is a kid for only so long, and as the years tick by, and I can understand why parents would be really concerned that if they're on a public waiting list that they're not going to get seen to, or if they if they're on even a private waiting list that it can be months and years of a wait for some of them. So can we chat a little bit about that, about like what people can do in the meantime?
Yeah, well, look, I mean, I think certainly within the classroom setting, there are things that can be done. And again, I can provide you with the list of sort of tips and tricks that are generally recommended. But simple things like, making sure a child sits near the point of instruction in the classroom, is given regular rest breaks, is given a position of responsibility to build their self-worth, self-esteem and confidence,
There's little seats you can buy them where they sit on the little seats and they can kind of wriggle around in the little seats or something like that. And apparently, so I've talked to some mums that have that in the classroom for their kids. Yeah,
absolutely. Well, I mean, in our clinic, I said we've got, we have the luxury of a complement of allied health professionals, including occupational therapists who can support kids in terms of maximizing their functional output. And if you've got a fidgety kid, sensory tools can be very helpful in terms of having something to kind of
fidget with
that isn't noisy or distracting to others. So fidget spinners, are out.
Yeah, God, they're awful jokes.
There's stretchy tangles and squeezy balls and all sorts of things.
Even I remember in our school they gave out Mola, or when I talk about our school, I talk about like my kids' school, Mola, or Blue Tack for kids to just literally.
It's called Theraputty now. It's not Blue Tack.
Theraputty. Jesus, there's a name for everything.
Is easily available online.
Okay.
And again, consult the show notes.
So, diet, is it important? How can someone maximize their child's diet to help them? And then are supplements a good idea?
I mean, there isn't evidence to support, a causal link between a child's diet and ADHD. Of course, I mean, if you find that giving your child a glass of Coca-Cola in the afternoon sets them off, you should probably avoid giving them a glass of Coca-Cola. They shouldn't be having it anyway. But
after their teeth.
Yeah, amongst other things. But look, everything in moderation and within reason. It will be unlikely that you will find, a diet that is going to substantially improve core ADHD symptoms if that's what the problem is.
Okay.
Notwithstanding that, all children should be encouraged to, enjoy a healthy, balanced diet, lots of exercise and lots of sleep, and limited screen time.
Okay. So first of all, I want to ask you about supplements, and then I want to ask you about screen time. I'm trying to get that into my head so I don't forget.
Yeah.
my attention span can sometimes be a little bit. So can people supplements? Can people take vitamins and minerals to help? Fish oils is there is this whole DHA, EPA thing.
Look, I mean, they can be effective to a degree. The fish oil, like omega-3 fish oils, their role is probably most manifest in kids that are on stimulants, because they can help modulate the efficacy of the stimulants themselves. So
can you explain what modulate the efficacy of stimulants mean?
Help them to work better. Okay. So omega-3 fish oils get a tick. Things like vitamin D get a tick. Sometimes magnesium supplements, etc., can help with sleep. So they get a tick. So beyond sort of vitamin D, a fish oil, maybe a multivitamin, we don't generally recommend anything beyond that.
So and then in terms of, say, the so you discussed sleep there. Melatonin, what are your thoughts on that? Because melatonin is available over the counter in the States and people can get it there, but it's on prescription only here. Yeah. And it's on prescription only in Australia, but it can really help children and their sleep pattern.
Yeah, that's very true. So in the kids that take stimulants and have sleep initiation or sleep onset difficulty getting to sleep, melatonin would be something that we would commonly co-prescribe with stimulant medication to help with that.
Because melatonin is produced naturally in the brain, so it's naturally kind of doing that circadian rhythm within your brain by taking melatonin. What are your thoughts on people, getting it shipped over from the States because they can't get a prescription here?
Yeah, look, I mean, we lots of families that we see do buy it online from the United States, and it works well. The only issue is you cannot be certain in terms of the quantity of active ingredient and other constituent ingredients within that formulation. So, it's sort of a bigger discussion that we probably don't have time to have today, whether melatonin should be on prescription or not. But as it stands, it's a prescription drug or medication in Ireland and Australia. And the best way of ensuring that you are getting what you have been recommended is probably to have a prescription filled. But in saying that, I have lots of families that order their melatonin online, and it works perfectly well. Yeah.
Okay. So we've done we did the supplements. Okay. So the screen time and the video games and the television and the fact that kids have phones, does that all add into the ADHD that we're seeing more of nowadays?
Look, potentially. I mean, again, it's kind of like the diet and exercise. Everything has to be done within, limitations. I mean, you don't want, like, of course, a child that games for 8 to 10 to 12 hours can present with many of the, clinical features of ADHD and other related disorders like anxiety or mood problems as a result of that, There are many benefits from video gaming as well in terms of fine motor skill development. It's a huge social outlet for lots of kids. I mean, certainly during coronavirus pandemic and all the lockdowns that were experienced in Melbourne, it was not just gaming, but social media and digital communication channels were often the only way of kids keeping in touch with their peer group. Kids are growing up digitally native, so it's it's the world that they experience. But I think parents would probably be advised, and I try to do it with my own 3-year-old, to limit the amount of time they spend on digital devices. Okay. And you can probably accommodate a little bit more screen time if the kids are doing other things like getting lots of exercise and sleeping well and eating well.
Yeah. Okay. And it can help improve concentration in some way. If they're concentrating on a game or they're doing something, at least they're concentrating on a game. Would there be a school of thought for that?
Yeah. Well, look, I mean, if you're I mean, there's been some nice studies from the States that show kids that are, gamers will, their performance improve, that they'll improve in their gaming performance, as is the case for any kind of extracurricular activity like sport, or a typical one in Australia, swimming lessons. Your execution of complex tasks and following of instructions will improve considerably when your ADHD is successfully treated.
Okay.
And that's often, similar to the kids who experience improvement in their sleep. That's often one of the, reported features of successful treatment from parents. It's like, oh my God, Sam, keep talking about Sam, he doesn't really exist. Sam,
if he does exist, he's suing you via his parents.
Sam can play basketball now. He listens to the coach. He participates with the team. Or Sam can, go through a karate lesson without sort of
annoying the
teacher and disrupting the class. So,
so there's loads of things there. Does anxiety often coexist in children that have ADHD?
Yeah, again, similar to the tics, they're common comorbidities. So about 30 to 40% of people with diagnosed ADHD will have a coexisting anxiety or mood problem. And then other behavioural problems like oppositional defiance and conduct disorder. But that's probably a podcast in and of itself.
What is that defiance disorder? That just give us a little snippet of it. I did get asked by a couple of people about it.
Yeah, look, I mean,
is it defiance disorder, or is it just your kid's an asshole?
That's not fair. Look, I mean, children that have ADHD can often present with behavioural features of oppositional defiance disorder, which is again a diagnostic entity within the DSM-5, but it can be an unhelpful diagnosis in a lot of senses. In that, more so than ADHD itself, there's a lot of negative stigma associated with oppositional defiance disorder. To your point, are they just a naughty child? Which can make, labeling a child with that something that needs to be considered. Yeah,
it's not. Seriously. It doesn't sound like a very nice term to label a child with that.
But kids with ADHD do have higher rates of those described entities, but predominantly anxiety and mood issues that often need co-treatment.
So they would need treatment. So, but would they, with the treatment of the methylphenidate, the ADHD medication, often like reduce the anxiety, or do they often need treatment for the anxiety as well?
It depends on the individual, and that's why the treatment needs to be tailored. I mean, people can experience improvement in their anxiety and mood symptoms once their ADHD has been treated.
Okay.
Sometimes people need medical treatment of both. So medication for ADHD and medication for anxiety or mood depression.
What would you prescribe for anxiety in a child and a 14-year-old?
For first line treatment from a medication perspective. Yeah. So not talking about cognitive behavioural strategies, which would be generally first line for anxiety disorder in children and teens. But first line medication would be something like an SSRI, so selective serotonin reuptake inhibitor like fluoxetine or sertraline, or some such.
Okay. Can ADHD be a response to trauma in childhood, or that a child's needs weren't met as an infant? Just kind of manifest as ADHD in later life? Is there studies to suggest this? Is there, can it be caused by toxins in the body? Is there something to do with the microbiome? There's these questions have all come up as well.
On the toxin side of things, I mean, infants that are exposed to prenatal substance misuse, be it alcohol, cocaine, methamphetamine, cannabinoids, there are studies to support that they're at higher risk of neurobehavioral disorders like ADHD, as is prematurity, an independent risk factor for a whole swathe of neurodevelopmental difficulty or differences. I'm sorry, what was the first part of that question?
Is it a response to trauma in childhood, or an infant's needs not being met?
Yeah, look, again, the etiology or cause of ADHD is multifactorial, multifaceted. There's many parts to it. Yes, there's a very strong genetic component, and yes, if you're a child or if you're a child that's experienced adverse events in your early developmental period, you are more at risk of receiving a diagnosis of ADHD. or other coexisting mental health disorders.
Okay.
So, the answer to that is yes, but it kind of doesn't change things in the sense that if a child is presenting with those difficulties, yes, they a contributing factor may have been early adverse childhood experiences, or ACEs, but that child still needs to be assessed and treated appropriately. Now, you may need to tailor psychological intervention to be more trauma focused, but in our experience in our clinic, they equally need medication if it's clinically indicated.
I think by toxins, I know we discussed drugs. I think by toxins, there is people are going around saying, toxins in our food or toxins in the environment, not the drug toxins that you're talking about. Can that contribute to ADHD?
Look, I don't have the data on that at hand, to be honest. Maybe you're alluding to heavy metals like lead and cadmium. Yeah. Look, I mean, we don't test for toxins. Some parents will present tests that have been done in the States or elsewhere, in Europe, sometimes like hair follicle samples that have been tested for a whole swathe of different things that show positive results, but they're very, very hard to interpret. And I mean,
are they a bit quackery?
Look, it's a bit of a pejorative term, but I wouldn't base my clinical decisions on.
I think you learnt the word pejorative from me, James.
Did I? I learned a few things from you.
I think I might have taught you that.
You told me I had to use the word pejorative at least once in the podcast to make you sound cerebral.
Does the microbiome affect ADHD? Or, is there a difference in the microbiome in a child that has ADHD? There's a lot of talk that goes on about the microbiome. I can't really find answers to it myself.
Yeah, look, I mean, I think there's the comment that I would make is that there's a paucity of, supportive literature to direct clinicians in terms of recommending, alterations to one's gut microbiome through either prebiotics or probiotics to, help modulate or improve ADHD symptoms. So, I mean.
But it's not something that's, done regularly,
no,
or
absolutely.
is it?
Well, certainly not in the Australian experience, no.
So it's not evidence-based then, is it? It's not.
No.
There isn't enough evidence to support its use. Is that what you're saying?
No. But look, lots of people use probiotics for all sorts of different things and report benefits from it.
Okay.
So, probiotics in and of themselves are probably safe, but would you recommend probiotics to treat ADHD? Absolutely not.
Okay. I used to traumatize my brother when he was growing up. James was very good in school, and when he annoyed me, when he used to annoy me, James used to be a very neat child, and when he used to annoy me, what I'd do is I'd mess up his books so they wouldn't be stacked in descending order in a school bag. And then on a couple of occasions as well, I used to tack when he really annoyed me, because there's only 3 years between us, so we used to fight an awful lot, and I would stick sanitary towels, now they were clean sanitary towels, on his homework. So he used to do his homework to an excellent standard, and I would deliberately stick sanitary towels to it just to annoy him. But you know what, he never ever acknowledged it, which meant that he definitely knew how to deal with me, because if he had risen to the bait, it would have just set off a nuclear war. But he was clever enough to know how to deal with me. So James, is it only stimulant drugs such as the methylphenidate that work, or there is a subset of people that don't respond well to them, isn't there? So are there options for them?
Yeah, there are. So look, I mean, although 80% to 90% of people will respond to stimulants, including methylphenidate and the amphetamine classes of stimulant medication, some people don't experience that or have intolerable side effects, in which case there are other options available. And in Australia, some commonly used agents would be the likes of atomoxetine, the brand name of which is Strattera, and a medication called Injuniv, or guanfacine is the drug name. And
so we don't have the guanfacine here. Well, I don't see it routinely prescribed. Strattera occasionally, but
and guanfacine, and although medications like clonidine, they aren't as effective for control of core ADHD symptoms. They're still in routine use in children, adolescents, and adults, particularly for sleep problems as well. But yeah, the mainstay of non-stimulant treatment in our practice would be atomoxetine and Ingenib. But we have, the results with the stimulants are generally favourable. So they're much less commonly prescribed.
Okay, and are they prescribed together ever?
They can be. They can be used as an adjunct of treatment. Yeah, they work in a completely different way from a biological point of view. Sometimes they can be used together. Yeah, the second line treatments. Yeah.
Okay. Is there anything else that you feel that people should know about ADHD before we wrap up?
Well, I guess just to finish, it's a chronic disorder. There are many useful and efficacious treatments available. They work well. They are safe. Yes, some side effects may be experienced, but in our practice in Melbourne, you're talking about response rates to one or other of the stimulant medications of up to 90%. So they work really well, and you can't say that for any other psychotropic medication.
No,
or medication.
It's remarkable,
that works
really.
on the brain. So they can be transformative, not just for the individual, but for the family and other people that are involved in their lives. So I would encourage people to kind of have a look through the resources that we'll provide, including some really good YouTube videos. And yeah, that will hopefully kind of bring some clarity.
Yeah, okay. Can I ask you why you moved to Australia?
That's a difficult question.
When did you move, James? I can't remember. How long are you there? 10 years?
Yeah, we've been there 11 years this year. So,
but you were right there when I had Oscar. So
we'd gone for a year to have a kind of working holiday on the Gold Coast in Queensland and enjoyed that, and came back and did. I did a few years of paediatric training here. My wife did a few years of ophthalmology training here, and then we decided, in the context of the kind of post GFC hangover and training opportunities, etc., to move to Australia, and it's kind of just gone from there.
Are you going to come back to me?
I don't know.
What's the like? Is there a nicer work-life balance over there for doctors? Is that why?
Yeah,
the
there
brain
is.
drain we hear.
I mean, bottom line is there are more doctors, and there's more capacity across services. Not although I mean, Australian healthcare is under a lot of strain at the moment, similar to what we're seeing in Ireland, probably to a lesser extent. But I mean, by way of example, I have a lot of emergency medicine physician colleagues, be it in pediatrics and adults. And there's 3 times as many consultants in emergency departments in Australia, and 3 times the number of junior staff as well, to help sort of filter through the inundation that they experience with people presenting. So, there's so many moving parts in these complex systems. You're never going to kind of elucidate all the difficulties in a short conversation.
Yeah.
But Ireland needs more consultants and an expansion of capacity within the hospital system. And healthcare has been unfortunately politicized to an extreme degree, and that's what's causing a lot of the difficulties here, I suspect.
And could you just say you decided that you wanted to move back? Could you easily come over here and set up practice, and would you be happy enough to do that, or is it just so lacking in kind of tertiary support, like what you're talking about, like the allied health that you were talking about?
Yeah, well, I, to be honest, I haven't really explored it as an option as of yet. But it is really helpful within our practice in Melbourne to have psychology and OT and speech pathology and dietitian, you know, within our service, because you do lean on those providers to help both in diagnostic assessments and ongoing therapies.
Okay.
Because specifically with ADHD, I mean, the diagnostic pathway will often involve a psychologist doing a concomitant assessment as well.
Okay.
Whilst we gather all the information from family, school teacher, in adults' case, maybe, you know, sometimes an employer, but usually not. But, you know, just kind of padding out that narrative or story to see if it fits the profile of ADHD.
Okay, so your answer is you're not coming back anytime soon.
Oh,
Mum's going to be devastated.
Who knows?
Okay, so at the end of my podcast, I always ask my guests 2 questions.
Okay.
So did I prompt you on this? Did I tell you this?
No.
Okay, well, so the first one is, what advice would you give young people today? And the second one is, what is the meaning of life, in your opinion?
Okay. So what would I say to young people today? I'd say be curious.
Okay.
And try and find, a mentor or an older person. And it doesn't necessarily need to be an adult, but someone that's just older than you that, you know, you look up to and can lean on for support and guidance. But be curious. Ask lots of questions about everything.
Just the way you were growing up.
I don't know, was I?
Yes. You remind me of my youngest. And then what's the meaning of life?
I have absolutely no idea. The meaning of life is probably to be kind to other people and be empathic.
Lovely. James, it's been a pleasure having my wonderful brother on the podcast. I'm delighted that you agreed to come on and you trusted me.
Thank you very much.
That I wouldn't make an absolute show of us. And I'm sure loads of people got loads off from this. And we are going to put all those references that James referred to into the podcast notes. So people can actually go in and they can have tools to kind of maybe start them on their journey or help them out if necessary. Thanks a million, James.
No problem. Thank you.